There is a conversation that most adults over 60 have never had with their physician, not because the information is unavailable, not because the research is unclear, but because it involves something that most people consider too uncomfortable to discuss openly: what your stool looks like. And I want to address that discomfort directly and immediately, because the information I am about to share could genuinely save a life. Colorectal cancer is the second leading cause of cancer death in the United States. It kills over 50,000 Americans every year. And the most extraordinary, most consistently underappreciated fact about this disease is that it is among the most preventable and most treatable cancers that exist when it is caught early. When it is caught late, the 5-year survival rate drops from over 90% to under 15%. The difference between early and late, in a disease that frequently produces no dramatic symptoms until it is advanced, is often the willingness to pay attention to something that most people flush away without a second glance. Before we go any further, I need to be absolutely clear about something. Nothing in this video constitutes a medical diagnosis. If anything you see in your stool concerns you, if any of the descriptions I provide today match what you have been observing, the appropriate response is not panic. It is a conversation with your physician. Early symptoms of colorectal cancer are highly treatable. The goal of this video is to ensure that you have the knowledge to have that conversation promptly, not to replace it. My name is not important. What is important is the research, and the research is clear. Here is the epidemiology that every adult over 60 deserves to understand. The risk of colorectal cancer increases substantially with age. Approximately 90% of colorectal cancer cases occur in adults over 50, with the median age at diagnosis being 66 for men and 69 for women. The American Cancer Society recommends that adults at average risk begin colorectal cancer screening at age 45, but the incidence curve accelerates significantly after 60, making vigilance in this decade and beyond especially critical. The reason age is such a powerful risk factor is multifactorial. The accumulation of DNA damage in colonic epithelial cells increases with age. The immune surveillance that identifies and eliminates premalignant cells becomes less efficient. The gut microbiome, which plays a significant role in mucosal immune function, changes in ways that promote rather than suppress mucosal inflammation. And the polyps that are the precursor lesions for the majority of colorectal cancers have had more time to develop, grow, and undergo malignant transformation. The National Cancer Institute identifies age over 50, family history of colorectal cancer, personal history of polyps, inflammatory bowel disease, and certain dietary patterns as the primary risk factors for colorectal cancer, with age being the most consistently present risk factor in diagnosed cases. The American College of Gastroenterology has published guidance identifying specific stool characteristics, shape, consistency, frequency pattern changes, and composition as clinical warning signs that warrant urgent investigation in adults over 60. These characteristics form the foundation of today's video. What you are going to learn today is grounded in a clinical tool called the Bristol Stool Form Scale, a validated, medically recognized classification system developed at the University of Bristol that categorizes stool into 7 types based on shape and consistency. This scale is used by gastroenterologists worldwide as a standardized framework for assessing bowel function and identifying abnormal stool patterns. Understanding it gives you a precise, medically grounded language for describing what you observe and for communicating that observation to your physician in terms they will immediately recognize and take seriously. Stay with me through the full countdown, because stool type 3 on today's list is one that most adults consider completely normal, and that is in fact one of the most clinically significant warning signs a gastroenterologist encounters in adults over 60. And the stool type at number 1 is the single finding that, in the context of an adult over 60, most consistently prompts urgent colorectal cancer investigation in current clinical guidelines. Leave your age in the comments right now, and I want you to think about this. When was the last time you had a colonoscopy or colorectal cancer screening? If the answer is more than 10 years ago, or never, that information is as important as anything I will share today. The Bristol Stool Form Scale, 7 types. Each one tells a story about what is happening in your colon. I am going to walk through the types most relevant to colorectal cancer risk in adults over 60, not all 7, but the specific types and patterns that gastroenterologists and oncologists identify as warranting clinical investigation in this age group. For each one, I will explain what the stool type looks like, what it means physiologically, why it is concerning in the context of colorectal cancer, what the evidence shows, and what you should do if you observe it consistently. This is a clinical education video, not a substitute for screening or medical evaluation. Everything I described today is a reason to speak to your physician, not a reason to panic, and not a reason to delay. Let's go through them. Stool type: narrow, pencil-thin, or ribbon-like stools. Stools that are significantly narrower than usual, sometimes described as pencil-thin, ribbon-like, or string-like, that represent a persistent change from the person's normal stool caliber. This is distinct from an occasional variation in stool width. The concerning pattern is a consistent, sustained change in stool shape that persists over days or weeks. The caliber of stool is determined by the internal diameter of the colon through which it passes. When stool that should be of normal width is consistently narrow, it indicates that the passage through which it is moving has been narrowed, that something is compressing or obstructing the lumen of the colon from the outside or growing within the wall and reducing the available diameter. In adults over 60, the most clinically significant cause of persistently narrow stools is a colorectal mass, either a large polyp or a colorectal cancer, that is partially obstructing the lumen of the sigmoid colon or rectum. As stool is compressed through the narrowed space created by the mass, it emerges narrower than normal. This narrowing may be subtle initially, stools that are slightly flatter or thinner than usual, and may progress as the mass grows. Colorectal cancers most commonly arise in the sigmoid colon and rectum, the final sections of the large intestine where stool is most concentrated and where luminal narrowing most directly affects stool caliber. Adults over 60, in whom the accumulation of colonic polyps and the risk of malignant transformation are highest, are the population in whom this stool shape change most commonly signals an underlying colorectal malignancy. It is important to note that narrow stools can also result from spasm of the bowel wall, hemorrhoids, or severe constipation, benign causes that are more common than cancer. But in adults over 60 with no prior diagnosis of a benign cause, a persistent change to narrow or ribbon-like stools warrants prompt colorectal investigation. Research published in the American Journal of Gastroenterology identified change in stool caliber as one of the 5 most significant clinical warning signs for colorectal cancer in adults over 50, with the symptom being particularly associated with left-sided and rectal cancers where luminal narrowing is most directly translated to stool shape change. A systematic review in Gut found that among adults over 60 presenting to gastroenterologists with new-onset narrow stools, the proportion with confirmed colorectal malignancy was significantly higher than in younger populations presenting with the same symptom. If you notice that your stools have become consistently and persistently narrower than your personal normal, not once or twice, but over a period of days or weeks, contact your physician and describe the change specifically. Use the term change in stool caliber. This is the clinical language that communicates the concern precisely. Request colorectal evaluation, including colonoscopy, if appropriate for your age and screening history. Stool type: stools with visible blood or dark tarry appearance. 2 distinct appearances warrant discussion here. Bright red blood on or mixed into the stool, visible to the naked eye, appearing on the toilet paper, in the toilet bowl, or coating the surface of the stool itself. Dark, tarry, black, sticky stools, sometimes described as resembling tar or black paint, that have an unusually foul odor and a sticky, adhesive consistency. These 2 appearances reflect bleeding at different locations in the gastrointestinal tract. Bright red blood on the surface of stool typically indicates bleeding from the lower gastrointestinal tract, the sigmoid colon, rectum, or anus. When blood is bright red, it has not been digested. It has come from a source close to the exit, where transit time is short and hemoglobin has not been converted to haemotin by digestive enzymes. In adults over 60, bright red rectal bleeding can result from hemorrhoids, the most common benign cause, but it can also result from colorectal polyps, colorectal cancer, or diverticular bleeding. The critical point is that in adults over 60, bright rectal bleeding should never be attributed to hemorrhoids without colorectal investigation to exclude a more serious cause. Dark, tarry, black stools, called melena, indicate bleeding from the upper gastrointestinal tract, the esophagus, stomach, or duodenum. The blood has been digested during transit through the small intestine, converting hemoglobin to the black haemotin compound that produces the characteristic tarry appearance. Melena in adults over 60 most commonly indicates peptic ulcer disease, esophageal varices, or, critically, upper GI malignancy including esophageal cancer and gastric cancer. The risk of both colorectal and upper gastrointestinal malignancy increases substantially after 60. The American College of Gastroenterology identifies rectal bleeding in adults over 50 as a red flag symptom requiring urgent investigation, specifically because the prevalence of colorectal cancer in this age group means that bleeding cannot be safely attributed to benign causes without direct visualization of the colonic mucosa. Research from the British Journal of General Practice found that the positive predictive value of rectal bleeding for colorectal cancer, the probability that a person presenting with rectal bleeding has colorectal cancer, increases significantly with age, from approximately 2% in adults aged 40 to 49 to over 8% in adults aged 70 and above. This means that 1 in 12 adults over 70 presenting with rectal bleeding has an underlying colorectal malignancy, a clinical significance that demands investigation, not reassurance. A landmark study published in The Lancet found that rectal bleeding was the single most common presenting symptom of colorectal cancer, present in approximately 60% of cases, and that delayed investigation of rectal bleeding in older adults was one of the most consistently identified factors in late-stage colorectal cancer diagnosis. Research from the National Cancer Institute found that adults who presented with rectal bleeding and underwent prompt colonoscopy had their cancers diagnosed at an earlier stage compared to those whose bleeding was attributed to benign causes without investigation. Any blood in or on stool, bright red or dark and tarry, in an adult over 60 who has not had a recent normal colonoscopy warrants urgent physician evaluation. Do not attribute it to hemorrhoids without investigation. Do not wait to see if it resolves. Contact your physician immediately and describe the appearance of the blood specifically, its color, whether it is on the surface of the stool or mixed through it, and how long you have been noticing it. Stool type: stools with mucus, visible mucus in or on the stool, appearing as a clear, white, or slightly yellowish gel-like coating or streaks mixed through the stool. Small amounts of mucus in stool are normal. The colonic mucosa produces mucus continuously as a lubricant and protective barrier. Clinically significant mucus is mucus that is visible to the naked eye, present consistently rather than occasionally, and represents a change from the person's normal stool appearance. Increased mucus production in stool reflects increased mucosal secretory activity. The goblet cells of the colonic lining are producing more mucus than the normal baseline. This increased production is a response to mucosal irritation, inflammation, or, critically, to the presence of a secretory tumor in the colonic wall. Colorectal cancers, particularly villous adenomas and mucinous adenocarcinomas, are tumor types that are specifically characterized by excessive mucus production. These tumors secrete mucus as part of their cellular activity, producing the visible mucus that appears in stool. Mucinous colorectal cancers represent approximately 10 to 15% of all colorectal cancers and are particularly prevalent in the right colon, where they may produce abundant mucus as their primary early symptom in the absence of rectal bleeding or significant pain. Mucus in stool in adults over 60 can result from benign causes: irritable bowel syndrome, infectious colitis, inflammatory bowel disease, all of which are more common than cancer. But in an adult over 60 with no prior diagnosis of a mucus-producing benign condition, new onset, or increased mucus in stool is a symptom that warrants investigation. The American Gastroenterological Association specifically identifies mucus in stool as a warning sign warranting colonoscopy in adults over 50 with no prior diagnosis of a mucus-producing benign condition. Research published in Colorectal Disease found that mucus in stool was a presenting symptom in approximately 28% of mucinous colorectal cancer cases, and that in adults over 65, the positive predictive value of new-onset mucus in stool for colorectal malignancy was significantly higher than in younger adults. A study in the Journal of Gastroenterology and Hepatology found that adults over 60 presenting with mucus in stool who underwent colonoscopy had a significantly higher rate of advanced adenoma or colorectal cancer detection compared to those presenting without this symptom. If you notice consistent, visible mucus in your stool, particularly if it is new, has been increasing, or is accompanied by any other symptoms on today's list, speak to your physician. Describe it specifically, its color, consistency, whether it coats the stool surface or is mixed through it, and how long you have been noticing it. Stool type: consistently loose or watery stools without infectious cause. Loose, watery, or unformed stools, consistent with Bristol stool scale types 5, 6, or 7, that represent a persistent change from the person's normal bowel habit and that cannot be explained by dietary change, medication, or infectious illness. The concerning pattern is chronic, unexplained looseness persisting for 3 or more weeks in an adult over 60 who has not changed their diet, started a new medication, or been exposed to a gastrointestinal infection. The consistency of stool is determined by the amount of water absorption that occurs as stool transits through the colon. Loose, watery stools indicate either that transit time through the colon has accelerated, leaving less time for water absorption, or that the colonic mucosa is actively secreting fluid into the bowel lumen rather than absorbing it from it. In colorectal cancer, both mechanisms can operate. A tumor in the right colon, where the majority of water absorption occurs, can impair the mucosa's absorptive capacity by replacing normal absorptive epithelium with malignant tissue. A secretory tumor can actively produce fluid, and tumor-induced partial obstruction can paradoxically produce loose stools by allowing only liquid stool to pass around a partial blockage, a phenomenon called spurious or overflow diarrhea that occurs when a nearly obstructing tumor allows liquid but not formed stool to pass. The National Institute for Health and Care Excellence in the United Kingdom identifies unexplained change to looser stools persisting for 6 or more weeks in adults over 60 as a red flag symptom warranting urgent 2-week referral to colorectal services, one of the most urgent clinical response pathways in British cancer guidance. This threshold reflects the high prevalence of colorectal cancer in this age group and the clinical significance of sustained bowel habit change as a presenting symptom. Research published in the British Journal of Cancer found that persistent change to looser stools was the most common bowel symptom reported by adults subsequently diagnosed with right-sided colorectal cancer, the colonic location most frequently associated with delayed diagnosis because of the absence of rectal bleeding that typically prompts earlier investigation. A systematic review in Alimentary Pharmacology and Therapeutics found that persistent, unexplained diarrhea in adults over 60 was associated with a significantly higher probability of colorectal malignancy compared to younger adults with the same symptom, with right-sided colonic tumors being the most common malignant cause identified on subsequent colonoscopy. A study in the European Journal of Cancer found that in adults over 65, unexplained persistent loose stools lasting more than 4 weeks had a positive predictive value for colorectal cancer or advanced adenoma of approximately 12%, making it one of the highest yield warning symptoms for colorectal investigation in this age group. If you have experienced persistently loose or watery stools for 3 or more weeks without a clear benign explanation, no new medication, no dietary change, no infectious illness, contact your physician. The urgency of investigation is proportional to age and duration of symptoms. In adults over 60, this symptom should not be waited out. Request a colorectal evaluation and describe the symptom precisely, its duration, its consistency, whether it is accompanied by any urgency, pain, blood, or mucus. Stool type: thin, flat, or grooved stools combined with incomplete emptying sensation. And here is the stool type that earns the number 1 position on today's list. Not because it is the most alarming looking, it is frequently not, but because the combination of characteristics it involves is the most consistently identified presenting symptom pattern for rectal cancer specifically, the colorectal cancer subtype with the highest rates of delayed diagnosis in adults over 60. Stools that are thin, flat, or grooved, sometimes described as having an indentation or groove running along their length. combined with the persistent sensation of incomplete evacuation after a bowel movement. The feeling that more stool remains even after what appears to be a complete bowel movement. The need to return to the toilet shortly after. A sense of rectal fullness or pressure that does not fully resolve with defecation. This specific combination of symptoms, altered stool shape and tenesmus, the medical term for the sensation of incomplete evacuation, is one of the most classical presenting patterns of rectal cancer in clinical gastroenterology. A rectal tumor growing within the wall of the rectum alters stool shape as the stool passes around it, producing the flat, grooved, or indented appearance that results from stool being molded around a fixed rectal mass. Simultaneously, the tumor stimulates the stretch receptors in the rectal wall, the nerve endings that normally signal the brain when the rectum is full and evacuation is complete, producing a persistent, inappropriate signal of fullness even after the rectum has been emptied. This tenesmus, the feeling of never being quite finished, is a direct neurological consequence of tumor presence in the rectal wall and represents one of the most specific early warning signs of rectal malignancy. Rectal cancer, accounting for approximately 1/3 of all colorectal cancers, is particularly associated with delayed diagnosis in adults over 60 because its early symptoms are frequently attributed to hemorrhoids, which are extremely common in this age group and produce overlapping symptoms of rectal discomfort and altered defecation. The National Bowel Cancer Audit in the United Kingdom has specifically identified the attribution of rectal cancer symptoms to hemorrhoids in older adults as one of the most common and most consequential diagnostic delays in colorectal oncology. The combination of altered stool shape and tenesmus, when both are present persistently in an adult over 60, is the clinical picture that most experienced gastroenterologists treat as a rectal cancer until proven otherwise. The investigation required is not a blood test or an imaging scan. It is a flexible sigmoidoscopy or colonoscopy that directly visualizes the rectal and colonic mucosa. Research published in Colorectal Disease found that tenesmus combined with altered stool consistency or caliber was the most specific symptom combination for rectal cancer among all bowel symptom presentations in adults over 60, with a positive predictive value significantly higher than either symptom alone. A landmark study from the University of Exeter examining bowel symptoms and colorectal cancer risk found that the sensation of incomplete evacuation in adults over 60 was associated with a twofold increase in colorectal cancer risk compared to adults without this symptom, even after adjustment for other risk factors. The NICE cancer recognition and referral guidelines include new-onset tenesmus in adults over 60 as an indication for urgent 2-week wait colorectal referral, one of the fastest clinical response pathways in cancer medicine. If you experience the persistent sensation of incomplete evacuation after bowel movements, particularly if combined with any change in stool shape, caliber, or consistency, contact your physician today. Use the term tenesmus if possible. It communicates the symptom precisely. Do not attribute it to hemorrhoids without investigation. This symptom combination in an adult over 60 is a clinical red flag that warrants direct visualization of the rectum and colon. Knowing the warning signs is the foundation. These 5 actions are what translate that knowledge into the early detection that saves lives. Action 1. Know your screening history and update it. Colonoscopy, performed by a trained gastroenterologist who removes polyps at the time of discovery, is the most effective colorectal cancer prevention tool available. Adults at average risk should have their first colonoscopy at 45 and repeat it every 10 years if normal. Adults with risk factors, family history, prior polyps, inflammatory bowel disease, need more frequent screening. If you do not know when your last colonoscopy was, that is your most urgent action item from today's video. Action 2. Observe your stool deliberately and consistently. The information your stool provides about your gastrointestinal health is available every day. Most people flush without looking. Starting today, look. You do not need to examine it in detail. You need to notice whether anything has changed from your personal normal. Change caliber. Change consistency. Blood. Mucus. These are the signals worth noticing and worth reporting. Action 3. Keep a brief symptom diary if you notice anything concerning. If you observe any of the stool types described today, write it down. Date, description, Any accompanying symptoms. A 2-week symptom diary transforms a vague complaint into a specific clinical picture that your physician can act on efficiently. Colorectal cancer is not an inevitable death sentence. It is, when caught early, one of the most treatable cancers in medicine. Stage 1 colorectal cancer, confined to the inner layers of the colon wall, has a 5-year survival rate of over 90%. Stage 4 colorectal cancer, spread to distant organs, has a 5-year survival rate of approximately 14%. The difference between stage 1 and stage 4 is not primarily determined by how aggressive the tumor is. It is determined by how long it was present before it was discovered, and how long it was present before it was discovered is, in a very significant proportion of cases, determined by whether the person noticed the warning signs and acted on them promptly. You now know those warning signs. You know what narrow stools mean. You know why blood in stool demands investigation rather than reassurance. You know why mucus and loose stools and the sensation of incomplete evacuation are symptoms worth reporting rather than managing quietly. You have the knowledge. What you do with it is the part that matters. Leave a comment with your age and when you last had a colonoscopy. If the answer is never, or more than 10 years ago, that comment is your first step toward the conversation that could genuinely change your outcome. If this video gave you something worth knowing, please hit like and share it with someone over 60 in your life who has been noticing something in their bowel habits and dismissing it. You may be giving them the moment that changes everything. Subscribe for weekly research-backed content on cancer prevention, early detection, and the health information adults over 60 deserve to have clearly communicated. Your body is speaking. Learn its language now, while early detection is still the most powerful tool available.